Welcome, everyone. I'm excited to welcome you to this episode of the Sunflower Podcast, a podcast exploring all aspects of children's palliative care around the world. Sunflower Podcast is bringing curiosity, humor, and reflection to the world of palliative care. We're exploring the joys and challenges of working in this incredible field, including topics related to education, advocacy, self-care, service provision, and leadership from around the world. My name is Rachel Neufeld, and I'm thrilled to be here as a guest host for this podcast. I'm a pediatric palliative care nurse practitioner in Vancouver, Canada, working for Canuck Children's Hospice. Today I spoke with Gail Andrews. She's a nurse both at the bedside and in research. Today we talked specifically about her role as a nurse clinician in research, and how are some of the things that she learned in research linked to her bedside job. Hi, Gail. Thanks so much for sitting down with me today. I would love to just hear a little bit about your unique role, both in research and your clinical work that you do.
Thanks, Rachel. I am a research nurse, which involves a couple of different things, but one of the things that I do is that I work both at the bedside and in an academic research environment. So my one job is as a bedside nurse at Canuck, which is a children's hospice in Vancouver. And I also work at the hospital in a research office with a bunch of computers. And so my day looks very different day to day, but I go back and forth between those two roles.
And both within a registered nursing role, then for both the research as well as the bedside.
That's right. It's a registered nurse, and the title is different. At the bedside, it's a staff nurse, and over at the hospital, under the auspices of the university, I am called a clinical research nurse.
I'd love to hear a little bit about that specific role as a nurse in research and how you might get into something like that. Do you feel like you were prepared as a registered nurse to get into research? Maybe you felt like you had to learn more about this role. I'm very curious about a nursing role within the research. Can you tell me a bit more about that?
That's actually a really great question. So my background is actually in psychology, and I have a master's in child development. And one of the things they really teach you in psychology is how to measure things and how to analyze them and how to show your results, because it's very difficult to measure things in psychology. So you do a lot of work about research and stats and that kind of thing. And I worked for many years actually as a research coordinator, where I was coordinating different research studies at the university with children and their families, and their situation was often that they were living with the experience of a child having a life-threatening condition, or perhaps they had a neurodegenerative disease and they were living day to day, coming and going from the hospital. And one day, one of the parents said to me, "You know, Gail, you're doing all this research and you're collecting all this data and all these numbers." She said, "But I got to tell you, the one thing that will really make or break my day when we get to the hospital is what nurse we have assigned to us that day."
So interesting.
Yeah, and she said that so clearly in one of the interviews, and I thought, you know, I need to get out from behind this desk, and that sounds like a job for me. And so I actually, not too long ago, enrolled in nursing school, and I went back to become a nurse. And so I am able to do both the clinical and the research by having a Bachelor of Nursing and a master's degree in research and child development.
That is so cool. That's fascinating. I love that that's the route that got you to this place. That's very unique. And I can also see how that would be really helpful to have that master's background in how you're communicating with families doing research too. I feel like that could be really quite helpful.
It is helpful, and I think that there's a lot to be said about having research as the background and then learning the nursing afterwards, which actually it was the nursing where I learned a lot more about communicating with families.
That's super interesting. So I'd love to hear from your research lens here. Is there anything new that's kind of stood out to you this year with some of the work that you've done? Something new you've learned, something surprising you've learned in the research, or has it kind of all been as you expected, your hypotheses all work out? What's this past year been like for you?
That's a really great question. And the thing that I learned is so surprising that I didn't know it before, which is that we really need to look closely. As clinicians, we need to ask questions. It sounds so simple. But one of the studies that I'm working on right now is pain and irritability for children with neurological conditions. And the reason why we started this research project is because about 10 years ago, we tried to do a study to figure out which drug would help children with unexplained pain and irritability. And these are often children that are in wheelchairs, they have trouble speaking, they're tube fed, and they can't really tell you where it hurts. And so it's really a guessing game about how you sort of treat these kids. And Dr. Hal Seiden and Dr. Tim Berlander did a small pilot project to ask physicians what it is that they would give as a drug to treat these kids. But at the beginning of the study, they also asked, what other things have you done to rule out the causes of pain? And for 6 children, they had 20 different things that had been done, but it was so scattershot, the number of things that hadn't been done. And so they actually took an entire step back and said, let's look at how we systematically assess pain in these children before we start talking about the drugs. And that led to what we call the PIUO, which is Pain and Irritability of Unknown Origin study. And I have just spent 2 years meeting with the physicians and the families and watching the physicians do a very thorough look at these families. And in almost 30% of the cases, we've been able to identify or treat the pain before moving on to anything else. Just a very basic, close look. Somebody called it the study of common sense. And that
30% you found a treatable cause.
That's right.
Wow.
Identified or treated. Sometimes you never know what it is.
Yeah,
you know.
Fair enough. Yeah, but 30% is a number bigger than I think I was expecting.
Yeah, it's a lot.
So then I also spoke with Dr. Seiden too about some of this, but I have found that approach feels really helpful for me as a clinician too, in that methodical approach of what are we assessing to rule out other underlying causes of pain before we're just using a particular drug. So that's super interesting. And I love that it comes down to the questions that we ask too, because that's something else I'm learning as I speak to some of you in research is what questions are we asking and how are we asking them? And that really curious approach to the research you're doing sounds like such a foundation for those of you doing research that I'm learning.
Yeah, absolutely. You're absolutely right. And it's not just what questions we're asking, but can we all please ask the same questions?
Good point.
Yeah. And then once we do that, what's our next step?
So I feel like I also spoke a little bit to this now. So linking this of how do you see, if any, a connection of the research to the clinical care that we're providing to children and families. So within some of the research work that you have done, are doing, do you see a link? Do you see a way to link that really academic research into the clinical care that we give to children and families?
Well, I'll give you an example of a time when I did actually link the research that I was doing to the bedside, but I think it does go both ways. I'll start with the example. Dr. Betty Davies has done for years not only excellent pediatric palliative care, but excellent pediatric palliative care research. And as she was wrapping up her illustrious career, she did a really deep dive into what are the best practices for clinicians. And she interviewed parents and she interviewed medical professionals and she came up with a list of things. There's a whole book about it. So, but one of the little tiny things that I took away is that a clinician should read a child's chart for at least 10 minutes before they go into the room to talk to the family.
Yeah. Right?
And it was such a small thing, but having read her study and all of the rigorous research that she did and coming to this conclusion, I now do that. I always try to do that so that I have this understanding. And so there's definitely a really nice way in which research funnels with me into the bedside. But I think sometimes the more critical component is actually bringing the bedside back to the researchers. And we know a lot of great minds are in research and we know that they're academically really doing these sound projects, but sometimes they forget what it's like to be at the bedside. And, perhaps it is possible to collect data on a child 24 hours, but you have to remind them that unless there's a nurse at the bedside, mom is maybe not going to get up in the middle of the night to measure the pH of a child's gastric tube. And so just these little things of knowing what it's like to the bedside and taking that back and helping improve research protocols so that they match what we're seeing at the bedside. And that to me is sort of the link that goes back and forth.
Yeah, and that's actually a really specific link I hadn't thought about in terms of the research protocols. So what are we expecting of the people caring for the child within the research project. But I also, as you were describing this return journey of questions back, so at the bedside, what are the questions we have that need answers? So within the care that we're providing, what are the questions that are coming up to say, we need more information about this? This is where our research needs to go. And so I can see that going both directions, but your answer is also quite an interesting separate link that I hadn't really thought about. So that's really cool. What do you find challenging about doing the research? Like some of that research work that you do. What's a challenge for you?
The biggest challenge for me is that it's so slow. As you say, we have so many amazing clinicians. I mean, even right here at Canuck Place that have great research ideas, but the pace of research is really slow. You've got to go to the ethics board. You've got to ask them if it's okay. Your protocol gets changed. And, it does take years to collect data and then to write it up, do the stats. And it can be a really long, slow process to actually get it out there. And something that I'm working on right now is a knowledge implementation project.
Ooh, yeah, that's a good one.
That's right, where we're trying to take some of the things that we learned in our pain and irritability study and translate those out into pediatric community centers. And that is very, very difficult because it's very easy to do something in an academic research institute attached to a, tertiary care children's pediatric center. And it's another thing entirely to do it in a small pediatric clinic that maybe has one pediatrician, no nurses, that's operating 5 hours outside of the next nearest center in the north of the province. So we're learning a little bit about the facilitators and barriers about what might allow us to roll out a research project into the real world.
Because that's the important part.
Yeah.
What do you love about doing research? What are some of the joys and the good things about doing this work?
I really do always feel like I'm making a difference. That is true at the bedside, and it is also true in terms of being a clinical research nurse, because you do see the changes, as slow as they are, you do see them being made, both in the way the research is done and eventually, hopefully, in the way the clinical care is being provided. It's a very positive space.
That's really good to hear. So then that kind of leads me to my last question for you too, that is, where do you think we need to go next? What do you think we need to focus on in terms of, some of the pediatric palliative care research that's being done? Where do we need to look next?
Well, I think that the real goal for me would be to steer our research towards outcomes in pediatric palliative care. And that sounds silly as a nurse, because I know when I'm talking about a good death, that I'm talking about the family being around and the child being comfortable and the lights being down and maybe the dog is at the bedside and the siblings have had a chance to say goodbye. And we all clinically really have this gut feeling about what a good death could possibly look like. But the research is way behind because it's very hard to capture numbers and data on what a good death looks like. And so we're starting to talk about things like embedding into the hospital or the hospice data set, what kind of components were there? Was there pain or suffering or excellent clinical care? The various things that we need to collect in order to show how to create a good death, but it's very hard to capture. And I would like to see more work go towards figuring out a way to measure that better.
It's so interesting because I've also struggled myself with the term good death. Because good is a statement of judgment. It's a biased statement. The one thing that I have learned as a clinician is that what I think is best or what would make a good death is not necessarily what that family needed. The timing of when things happened, the location of where things happened. I have learned in my follow-up with families about their perception of how everything went. And I learn each and every time, again, keeping my bias in check, because my judgment, not in a negative way, but my judgment of how I think this needs to go. And so when I say a good death, well, what does that mean? That means something completely different to me than to someone else. What a subjective, personal thing to have to try and study, which seems like an enormous undertaking, but I would love to hear more about that, because I think I have had to remind myself over and over and over again that it's not just about what I think is right or good or best or whatever. We all want a child to be without suffering. I feel like that's a common denominator we can all agree on. But what makes those good things is so incredibly subjective. I think that would be some powerful research.
Oh, yeah. I mean, and it's absolutely right. And not only that, but if you're having that big emotion about how subjective and the meaning of it and the different perspectives of it, imagine now trying to quantify it.
Nope.
It's just really no way. And I think that is very true what you say. My idea of a good death might not be somebody else's, might not be the family's, might not be the parents, might not be the siblings, might not be the child's. And I think that is really the future of research, is inviting families in. That the research is parent and patient oriented. It's about the families because the families have asked for that kind of research. It's about the patients because the patients have given an indication of what they think the research should be about, or even better, how it should be done. And so I really think patient oriented research, which is really a trend that is starting to happen now, is really the future. It's not my definition of a good death. It's asking families and parents, where do we need to take this?
Yeah, and that qualitative research, I think, has always struggled to be, forefront, because people want numbers and data. And even PIUO study that you were a part of was very data driven, as opposed to a very subjective qualitative narrative, whatever kind of design you choose, but having that hold the same amount of power. Obviously, the data is different than an RCT, like randomized control trial, but in the pediatric palliative care world, where we think outside the box so much and we function, beyond the norm, RCT might not be our gold standard for how we learn about how to do our work the best. So that honing in on really good qualitative research sounds like a feat, but also some really rewarding work. I look forward to seeing more of that from you, Gail. Thank you so much for taking the time to sit down with me, chat this through. It's a delight. I love hearing different perspectives of different roles within research, a physician role, a nursing role, PhD researcher role. It's been really nice to sort of hear how they all fit in, but everybody has a slightly different perspective and a different work and job within that research, so that hopefully we get a bit more of a wholesome approach to what's being done. So thank you very much.
Thank you.
Thank you for listening to this episode of the Sunflower Palliative Care Podcast. These podcasts grew from a seed of an idea as we talked with our colleagues in the Sunflower Children's Network. The Sunflower Children's Network is an initiative of Two Worlds Cancer Collaboration, which focuses on children's palliative care. We hope to build a world where no child suffers from serious health-related issues. To learn more or to donate, please visit twoworldscancer.ca.